Okay.
Yeah.
Okay, so our group explored a case study of a 6-year-old girl with joint pain. So the first incident. The patient fell on her outstretched left arm and felt pain in her arm throughout the night. So she went to the emergency room the next day. However, radiographs of her arm were completely normal. Over the course of the next 16 days, the pain migrated to the joints in her distal arm, which limited her daily activities. Her pediatrician found that the distal humerus was slightly tender, but the remainder of that examination was also normal. On the 17th day, the patient visited an orthopedist at Massachusetts General Hospital, and her examination revealed pain over her left biceps. Other than this, her results were normal. After about 3 weeks, the girl's pain went away completely on its own, and over the next 6 months, she occasionally complained about pain around the rib area on her left side. The second incident. So 6 months later, the patient awoke in the middle of the night with knee pain after a very minor fall on the grass, which was obviously concerning for her parents. She had a slight limp from this injury, and the patient's pediatrician found that the right tibial tuberosity was slightly tender. However, there was no swelling or effusion, and a radiograph of the knee was completely normal. And the patient was seen in the rheumatology clinic a week later. But seeing as the only problem was the pain from her fall, she was released from the hospital, and her parents were told only to bring her back if her symptoms worsened or another episode occurred. So, unforeseen symptoms. 5 months prior to the patient's admission to the hospital, she presented with conjunctival injection, which is essentially just red eye due to the prominence of superficial blood vessels on the conjunctiva, and there's a picture of that there. That's not the patient, though, it's just an example. And so 3 months prior to the patient's admission, she presented with severe non-pleuritic pain in her left flank, so this meant that her breathing was still normal. The pain was not improved with ibuprofen, however, it did resolve on its own 2 days later. There was moderate cervical lymphadenopathy, which is just a disease affecting the lymph nodes. However, the remainder of the examination was normal and she was released. So by now this was kind of a pattern, that her urinalysis tests and her x-rays would show normal results, and her pain usually resolved itself on its own, which led doctors and her parents to believe that her medical problems were isolated instead of part of a larger disease. And it's also really important to note that the patient was under a rheumatologist's care up until this point and for the entire year prior to her admission to the hospital. And it's actually very common for children with leukemia to present symptoms similar to those of arthritis. And the interpretation of this patient's symptoms as a part of the rheumatology unit was a crucial mistake that doctors kept making throughout her care until she was finally referred to the oncology unit. 6 days before her admission, her symptoms worsened. She was evaluated by her pediatrician because she had severe back pain, she was limping, and she had an intermittent fever that rose up to a temperature of 39.8 degrees Celsius, which is almost 104 degrees Fahrenheit. And then on examination, her test results were normal with the exception of mild swelling of the left palpebra superior and presence of serous fluid behind both otic membranes. And then finally, a day before her admission, the patient had swelling around her right eye, she had abdominal swelling, and discoloration around the umbilicus region, along with a fever of 39.4 degrees Celsius. So on the day of admittance, the patient's weight was 27.7 kilograms. There was bilateral periorbital swelling, right periorbital erythema, and bluish discoloration below the left eye. So this is just a picture of a person who shows erythema underneath her eye. Her abdomen was soft and tender, and there was periumbilical firmness with discoloration of the overlaying skin. So this was especially concerning to doctors. The patient was referred urgently to the Rheumatology and Oncology unit of the hospital. So doctors were interested in the family history. So up until this point, the patient's growth and development had been completely normal. She lived with her parents and lived a normal life as a 6-year-old, attending school and dance classes. Myocardial infarction, breast cancer, eczema, and rheumatoid arthritis all ran in the family. However, it's important to note that there was no family history of childhood arthritis, as the doctors had presumed that her symptoms fell under. Upon examination, her temperature was slightly high. She had a fever, but her blood pressure, pulse, weight, and height were all normal. There was discoloration below the right eye. Her abdomen was still soft and non-tender with normal bowel sounds. There was a firm mass in the lower midline and bruising around the umbilical. So this abdominal mass was kind of the tipping point that ultimately caused doctors to refer the patient to the oncology unit instead of rheumatology. The patient also flinched when the hip was externally rotated and she walked with a slight limp. However, the remainder of the examination was normal. Her blood tests did not present anything remarkable, and her renal and liver function were good. So doctors first tried to place the patient's symptoms under one of these three categories. So they ruled out infection just because of the nature of her long-term symptoms and her lack of fever. They ruled out inflammation due to the acute onset of her symptoms. Her pain was very sudden and severe, and so they decided that this was an oncologic diagnosis due to the severity of her symptoms and lesions on her liver, which can be seen in the picture there, and then enlarged kidneys and as well as enlarged lymph nodes.
In order to further narrow in to the differential diagnosis, we took a look at three things, neuroblastoma, leukemia, and lymphoma. In order to take a very specific look at neuroblastoma, doctors took a look at the expected symptoms and the clinical manifestations in the patient herself. So expected symptoms for neuroblastoma would include eye discoloration, normocytic anemia, high levels of ferritin, as well as an elevated level of lactate dehydrogenase. When considering neuroblastoma, the location and origin of any malignant tumor is also very important. Clinical manifestations in the patient herself included normocytic anemia, elevated levels of both ferritin and lactate dehydrogenase, which correlated to the neuroblastoma. However, the involvement of the kidneys was atypical of someone with neuroblastoma, as well as the location of the abdominal pelvic mass in the anterior lower umbilical region. If you look to panel A, you can take a look at the enlarged kidneys, as well as panel B shows the abdominal pelvic mass, which we are taking a look at. On the next slide, we can take a look at leukemia. So the expected symptoms for leukemia include bone pain as well as a lower blood count. Our patient did exhibit bone pain as part of her clinical manifestations due to skeletal lesions on the bones, her bones. However, CBC findings for blood count found that her platelet levels were relatively normal. Typically speaking, patients will have lower than 100K platelets if they have leukemia. However, our patient had 366K, which is pretty good for normal. On the next slide, we can take a look at lymphoma. Expected symptoms for lymphoma include eye discoloration as well as the extramedullary tumor masses. When considering lymphoma, it is also important to take into account the location and origin of any malignant tumors. Clinical manifestations in our patient that correlated to the diagnosis of lymphoma included eye discoloration, as well as metastasis to the bone marrow, bone, liver, and skin. Also in the manifestations in the patient herself, normocytic anemia, high levels of ferritin, and lactate dehydrogenase also helped doctors reach the conclusion of a lymphomatic diagnosis. If you take a look on the CT scans, on the one further up, you can see the location of the abdominal pelvic mass as well as the involvement of the lymph nodes in panel D, which is pretty important when diagnosing a lymphoma. Next one. Here more specifically, we can take a look at both neuroblastoma and lymphoma and the different categories which help distinguish the two. So if you look at neuroblastoma, you can see that the peak incidence is up to 10 years of age. and most importantly, the location in the adrenal glands is specifically rising from the sympathetic chain in the posterior abdomen. And you can also see the metastasis, or the spread of the malignant tumors as well. They spread to the bone marrow, liver, and skin. When looking at lymphomas, you can see that they arise from typically any age, as well as their location and origin in the abdomen. They may also involve the bowel, ovaries, liver, and kidneys. It's important to note that the kidneys were involved in the patient herself because that was one of the things that distinguished the two. You can also see in the pattern of spread here that the bone, skin, bone marrow, and cerebrospinal fluid were part of the decision to diagnose lymphoma as part of the diagnosis. When looking at non-Hodgkin's lymphoid precursor neoplasms, it's also very important to take into account the cell type. Right away, we could rule out anaplastic large cell lymphoma due to the lower levels of lactate dehydrogenase, which were not presented in our patient. She had elevated levels of lactate dehydrogenase, so we can rule that one out. And then T-cell lymphoblastic leukemia is typically found in males. However, it is also presented with an extramedullary disease that has an absence of bone marrow involvement, which our patient did have bone marrow involvement, so we can rule that one out as well. And we are left with our diagnosis, B-cell lymphoblastic lymphoma leukemia. And B-cell lymphoblastic lymphoma is one of the most common childhood cancers. Its manifestation as lymphoma can be seen in the patient's symptoms and clinical manifestations, such as the tumor itself and where it was found. So if we take a look on this slide, we can see the different histological samples taken from the patient, both from the tumor itself and from bone marrow. If you look on panel B, you can take a look at the concurrent bilateral bone marrow core biopsies, and that on this panel you can see the different primitive appearing cells, which are markers of B-cell lymphoblastic leukemia, more specifically the biomarkers that are positive for this lymphoma. If you take a look at panel A, you can take a look at the immunohistochemical analysis, which is that smaller subset, and was used to using flow cytometric analysis on panels C and D to sort of explain what biomarkers were found and how they can prelude or show the different markers or diagnosis for B-cell lymphoblastic leukemia. In the end, they decided to give the patient a couple rounds of chemotherapy and a couple bone transplants as well, bone marrow transplants as well.
All right, so now we're going to take a little bit of a deeper look at the actual test results that confirm that acute lymphoblastic leukemia-lymphoma was the actual diagnosis. So here we have a bigger picture of the bone marrow histology. You can see some hemorrhaging in the photo, and you can also, I can see that well from back there, but there's irregular nuclei, and the cells tested positive for primitive lymphoid cells or lymphoblasts. And then over here on the chart, you can see the hemoglobin levels are relatively low, which indicates anemia, which can be infection, and it's commonly seen in most cancers. And then also, the patient has leukopenia, which is a low white blood cell count. It indicates that that she had a low rate of functioning white blood cells. And as noted earlier, there's low lactate dehydrogenase levels, which indicate tissue damage, and in our patient's case, they indicate the malignant tumor. And then just what the actual disease is. B lymphocytes are produced in they're white blood cells produced in the bone marrow, and they help fight, they're antibodies that help fight disease. Acute, as opposed to chronic, just indicates it's an aggressive form. And then lymphoblastic indicates early stage or immature B cells. So on this flowchart, you can see the normal progression of red and white blood cells. So the patient's white cells should have followed this path, and they stopped about here, and that's when they became irregular. And then their ALL and LBL are considered differential stages of the same disease. So in LBL, it's a form of non-Hodgkin's lymphoma, and the development often begins in the axillary lymph nodes. Non-Hodgkin's lymphoma accounts for 7% of childhood cancers, and LBL accounts for only 25% of NHL. However, there is an 80 to 90% 5-year survival rate in children. There are 6,000 new cases a year in the United States and 1,400 deaths a year. An interesting thing about ALL is there's a 90% 5-year survival rate in children under 14, but as the age of diagnosis increases, the survival rate decreases. So people over the age of 65 that are diagnosed have a 15% chance of survival. And then there's been a lot of debate whether they are connected or not. Michael Kelly, the treating physician, agreed that ALL is when 25% or more of the bone marrow is involved, and LBL is when less than 25% of the bone marrow is involved. There's also some research that says it may be a form of a lymphoproliferative disorder that has to do with immune insufficiency. And BALLBL is only 2% of diagnosed lymphoid neoplasms, so it's pretty rare. And then for us, the takeaway for this case is that leukemia and often other cancers can present as rheumatology or orthopedic problems. Dr. Michael Kelly did a retrospective review of the past 15 years at Floating Hospital for Children, Boston, and British Columbia Children's Hospital in Vancouver. And 29 children were sent to rheumatology and then later found to have malignant tumors. And although this only averages to about 2 children a year, that's only 2 hospitals, so we can assume that it happens in a lot of rheumatology clinics, and it probably happens to a lot of children. Like as stated earlier, in our patient's case, she was sent to rheumatology for over a year before being sent to oncology. And arthritic leukemia is a common symptom, and it's due to the increased synovial fluid in the patients. Oncological causes of musculoskeletal symptoms should be ruled out, especially in presentations of atypical and in monoarthritis, atypical pain. So it's also common in Ewing sarcoma, neuroblastoma, and osteosarcoma that they present with bone and joint pain. And the reasons that it's important to take this into consideration is in lymphoma, stage 1 has a 20% better chance of survival than stage 4, and in osteosarcoma it rises to 30%. So in order to get an earlier diagnosis and a better prognosis, this needs to be taken into consideration. Sadly for our patient, she was treated several times and went through 2 bone marrow transplants, but after 20 months after the diagnosis, the patient did pass away. So the important takeaway is, in order to prevent this misdiagnosis, the family history needs to be taken into consideration. This patient had no family history of childhood arthritis or childhood rheumatology problems. Also, atypical pain and monoarthritis in large joints such as knees or elbows should be thought of as a precursor or questioned, as well as bruising that takes a long time to go away. And also, with these taken into consideration, if the patient does have atypical pain and no family history, image testing such as CT scans should be performed to find tumors.
Excellent, young ladies. Excellent. Any questions, comments from the med students? Kelsey?
I just want to make a comment. I think that you guys did an incredible job. I mean, I'm sitting here trying to put myself in your shoes, and I think if I would have gone up there and done a presentation, you guys still would have looked far better than you have. And I'm not just saying that. Really, you guys did an amazing job. You were well prepared. You clearly did your research. I thought it was a really good presentation.
Alex?
Excellent presentations were very thorough, very well done. Just presentation techniques by all of you. And actually, for me, I thought you were sort of wondering and thinking about this. I don't have the answers to the questions that's actually brought up, i.e., if this patient's losing, why is that happening? She has a normal platelet count, unless the dysfunctional platelet for some reason. Number two, why the kidney problem? I assume it may very well be due to obstruction of the ureters and bilateral hydronephrosis rather than primary tumors of the kidney. Just some thoughts going on, but spurred by some presentation.
Was there a discussion in the paper about why the rheumatologist might have missed this for a year? Is there any talk about that?
The pattern of when she visited the rheumatologist clinic, so she kept coming every time she'd hurt her hand or her knee or her hip, but the pain would go away eventually. It wouldn't be something constant and systematic.
So they just said like come back if it worsens or prolongs.
Yes, but I would defy any of us to go into a rheumatologist's office and leave without a blood test. They always get blood tests. Students?
So, I guess
Matt?
a follow-up to that question is, do they do blood work and test for any rheumatology markers or anything like that?
They tested at the beginning. They did a urinalysis and they tested for lupus. But before they actually thought it was oncological, it didn't say that they did any blood work.
Any thoughts? John? Do you remember the hematology stuff for that whole year? The white count was fairly okay, 10 grand. Platelets, 300,000. Mild anemia.
That's part of the problem, I think.
If you do a white count without a mandatory diff, you'll never see the lymphoblasts if the white count's known. So you can have what is called aleukemic leukemia. Leukemia meaning blood rich with white cells. Aleukemic leukemia meaning normal white counts, but a leukemic process. And unless somebody looks at the blood smear, you won't make the diagnosis. And the patient can go a year without proper therapy. We got 3 minutes. You want some history? Some history of this? The Dana-Farber Cancer Institute was built on the foundation of treating this disease in the 50s by a pediatrician who wasn't even at that time singled out as an oncologist or pediatric hematologist named Sidney Farber. And he started giving these children cyclophosphamide, which was really the only anti-metabolite around. And he was getting remarkable remissions and cures, such that the Boston Red Sox started raising money to build him a building. Anybody know what the name of the building was? Alex, you know what the building was. The Jimmy Fund building. The Jimmy Fund building then became the Dana-Farber Cancer Institute, built with philanthropic funds from grateful parents whose children were saved by Sidney Farber, with a very simple single anti-metabolite, Cytoxin. The points which these young ladies made were get them early and treat them early, and they do very well. But delay the treatment and you have disastrous results. And then a personal note, I was at the medical school there in the early 60s when Sidney Farber was there. He looked like Santa Claus. He He had this big white mustache and beard. He was very ruddy. He was very roly-poly. He was a natural to take care of little kids. They just sort of gravitated to him. Some of them just run to him because he looks so Santa Clausy and grandfatherly. And very powerful people from all over the world would come with their children. Sheiks from Saudi Arabia, Asian potentates, and high-class, wealthy people from Europe bringing their children or their children's children to be treated for this disease, which was and still is very, very common and is now curable. Okay, thanks very much. That was wonderful.